Okay.
Yeah, live, please.
Good afternoon, everybody, and a warm welcome to Module 5 of this AIOS-supported certification program for myopia progression control. Today, this is Module 5, and we would be talking and discussing mainly about the spectacle options for myopia progression control. So I would be asking my two moderators, Dr. Mayank Jain and Dr. Ketki Subedar. So they will be introducing the speakers and we will begin the session. Please go ahead.
Good afternoon, everyone. Thank you, Dr. Jethani and AIOS for the opportunity to be the moderator for this Module 5 of the certification course for myopia management. For so far, we've covered the real-world scenario of myopia. We've covered the pre-myopia, covered the myopia documentation, and the need for low-dose myopia. Today, we are going to talk about the one question that does a pair of glass help with myopia progression? And for that, we have expert panelists and we have some esteemed speakers. We will quickly go through their names. Dr. Arun Sampati, Dr. Anthony, Dr. Ipshita Basu, and Dr. Aati Elians as panelists. And speakers are Dr. Sumita, Dr. Kalpit, and Dr. Amit Gupta for different topics. Dr. Mann, do you want to introduce the first speaker?
Yeah. So it has been a great pleasure to introduce Dr. Sunita Muthu, and she will be talking about peripheral refraction and axial length growth. So this is very important because now we are talking about myopia control glasses, and our myopia control glasses are based upon peripheral refraction. So whom should we do it? Whom to do it, how to do it. So I think Dr. Sumita will be shining great lights on that. Over to you, Dr. Sumita.
Thank you, Dr. Mayank. So I'll share my screen now. Please let me know if you can see the presentation.
So this is Dr.
I think
Namrata.
before, yeah.
I'll just
Yes,
say a
yes.
few words. And thank you again, Dr. Jitender, for doing this. It is a great course, and you can even take it even if you are not live. And of course, the certification will also be done, and I think that is the most important thing. And today, again, it's a very important topic, spectacles, related to spectacles, which is the all and be all of myopia. And over to you, everyone. And I would like to thank particularly the panelists and the speakers for being with us today and for making this happen. And also all the delegates who have joined online. So thank you so much.
I hope you can see the screen.
Yeah, very well.
Thank you, ma'am. Thank you so much for the opportunity.
A word of thanks.
And yes, go ahead, Dr. Jethani.
No, yeah.
Okay. So, yeah, I hope you can hear me. And so I'll be throwing a little light on what peripheral refraction is and why we're talking so much about peripheral refraction these days, especially with so many optical treatments in the market. So we all know about emetropization. So emetropization is nothing but the refractive error normalizing and the eye coming close to a zero refractive error. So when does this process occur? This process occurs usually in the first 7 years of life. Okay, and usually everyone starts off being hyperopic, and most of them start off being hyperopic, and by the time they reach about 7 years of age, the axial elongation happens, the length of the eye increases, and emetropization occurs. So what exactly happens in emetropization? What is proposed is that there is a peripheral hyperopic defocus. Okay, so you can see that this is a myopic elongated eye with correction, with a concave lens correction. And you can see how the central rays are being focused on the retina, but the peripheral rays are being focused behind the retina, creating a hyperopic defocus. And this kind of hyperopic defocus is actually normal for an eye which is emetropizing, but then abnormally persists in case of a myopic elongated eye. That is a theory that is proposed. So this is a hyperopic defocus that we are talking about. Here again, you can see whether it is contact lens, a conventional contact lens, or whether it's a spectacle lens. What happens in myopia is that the central rays are getting focused on the retina, but the peripheral rays are being focused behind the retina, causing a persistence of this hyperopic defocus and abnormal elongation of the eye. So here again, we are going to talk about how peripheral hyperopic defocus is important in myopic patients. We textbooks and other reading material respect to peripheral children. So see progression. One of them is emmetropization, or this feedback mechanism that I was talking about. The other factors being dopamine and scleral biomechanics, accommodative lag, okay, peripheral refraction, as we already spoke about. So what is the role of peripheral refraction in myopia progression? Hooger and Hare et al. Progression, and this kind of. So, what are the various? Why are we talking about peripheral refraction? Is there are various treatments that are based on this peripheral defocus theory. One is, of course, the ortho-K lenses. The other is the DIMS, or the defocus incorporated multiple segment lens. These are by Hoya, and the halt or highly aspheric lenslet technologies. This is also called Stellest, and this by Essilor. And we also have these soft ortho-K lenses, which mimic the ortho-K lenses by in terms of hyperopic defocus and in terms of the peripheral hyperopic defocus that it peripheral myopic defocus that it creates. But of course, these are soft lenses and have to be worn during the daytime. So these are all the various optical treatments that are exclusively based on this peripheral defocus theory. But so this is the sorry. So this is the kind of defocus that happens, and what are the supporting points in terms of this theory? So we always know that there is a mid peripheral feedback theory. We know that all these optical treatments have proven to be effective in terms of various studies which have happened in the Western population, in Singaporean population, in Chinese population, as well as we have recent studies in the Indian population as well. And we know that these treatments, which are based on peripheral defocus theory, have worked. So these are the supporting points for this theory. But what are the opposing points? What are the opposing points are on reading? There is a myopic defocus which is induced peripherally. But we all know that reading, that is excessive reading, is not a behavior that is protective against myopia. And we also know that there are higher order aberrations in the periphery which negate the myopic and hyperopic defocus. Then why should this kind of peripheral hyperopic or myopic defocus matter? So these are the opposing points against this theory. Again, there are other ways through which ortho-K may act, for example, by increasing depth of focus in the periphery. So we don't know if it is this mechanism or, their induction of a myopic defocus that is helping in controlling the myopia progression. So these are all the points in favor of this theory and the points which oppose this particular theory. So we wanted to see if peripheral hyperopic defocus is the cause or the consequence of myopia was a question that was always in our mind because of the various supporting and the opposing points. So with this in mind, we intended to study the peripheral refraction in progressing myopic patients. And Western population, told us, Western studies have told us that peripheral hyperopic defocus is very common and exists in almost 60 to 70% of the myopic children. So we presume that that's what we are going to find. And with that in mind, we wanted to study this peripheral refraction in children. So this was a retrospective cross-sectional study. We looked at the peripheral refraction values of many children who were prescribed various kinds of myopia control treatments. So overall, about 137 pediatric patients were included, and we did the peripheral refraction using an open field autorefractor. The other means of doing the peripheral refraction would be to test it manually. Basically, you give them targets at different angles and make sure and do a peripheral refraction of the retina. Basically, do a regular refraction, but this will give you the refraction of the peripheral retina, and you document the small changes that you find. However, minor changes can be very challenging to appreciate in terms of peripheral refraction. Dr. Jetani has done extensive work on this, and he's come up with devices that can help us with this kind of peripheral refraction. The LBPI team has also come up with certain kind of lights which can help us understand what is the angle that is subtended, and then measure the peripheral refraction. So there are various ways to do it manually. So then these kind of patients were actually prescribed any myopia control treatment based on the patient's, the parent's choice, and based on the kind of progression that they showed. So this is an open field refractor. You can see that this is the so as opposed to a normal autorefractor machine, this has these transparent lenses through which the patient can see the wall that the patient is facing, and they are made to look at different targets. First, central refraction is documented, and then you document the peripheral refraction. So what literature says is up to about 30 degree of peripheral refraction is important. So what we did was we did 10, 20, and 30. We also took 1 point superiorly and inferiorly, because there were some studies which spoke about hyperopic or myopic defocus in the superior and inferior retina being significant, because because when we are reading, it is the superior retina that is getting stimulated more in down gaze, and therefore they said in this particular part of the retina, any defocus can be significant, is what is proposed in some studies. So we also wanted to look at this. So this is how a child is made to sit on the machine, and then we show all these targets. These are targets that are pasted on the wall. Well, earlier we used to look at every 10 degree for almost 30 degree in the vertical meridian, and almost every 10 degree in the horizontal meridian. But later, with experience, we found that it's very difficult to get the peripheral refraction in wide angles, and also in terms of literature, which supported only the first 30 degree being quite significant. That's why we eliminated other angles in further studies. So this is how we documented our refraction. So you can see we first looked at the central refraction that is documented. We look at the spherical equivalent, and then we see how the spherical equivalent changes in the nasal 20 degree, 30 degree, temporal 20 degree, 30 degree, superior and the inferior part. Okay, so this is how we documented the peripheral refraction. So what were the results of our study is that we found that most of them, as opposed to the Western population studies or the Chinese population studies, most of them were myopic. The blue indicates the myopic defocus, and the orange indicates children with hyperopic defocus. So only 42% in our study showed a hyperopic defocus. So the average myopic defocus that we got was about 1.3 diopter, and it ranged from 0.6 to as high as 4.6. Especially in high refractive errors, we found that the defocus can vary a lot. So again, in hyperopic defocus, our range was between 0.5 and minus 6.38, but the average was again similar. It was about plus 1.35 diopter. And looking at the treatment aspect, so I told you that it was a retrospective study, so we had already prescribed these children some treatment. So most of them had actually received peripheral defocus glasses. There were some on low dose atropine. So it is based on this peripheral refraction that we advise them that those with hyperopic defocus could go for the optical treatments, which may work better for them, is what we had advised. And so hence most patients and parents chose the glasses. But there were some parents who said that the cost is too high and they still would like to prefer using low-dose atropine. Those were the ones that were given low-dose atropine. Then there were a few patients who were also given ortho-K lenses. So if you look at, this is with respect to the hyperopic defocus group. But if you look at the myopic defocus group, most of them were encouraged to be on low-dose atropine eye drops because we did not find a hyperopic defocus then. So if you look at the literature and how they've looked at peripheral refraction, Donald et al. Found they looked at peripheral refraction and the ocular shape in children. So what they found was peripheral hyperopic defocus compared, was more common in myopes as compared with emmetropes. So that is again a study which is in support of the peripheral hyperopic defocus theory. Again, the sample size was huge over there. Then there was another study by Jamal, and they found, that myopic children had relative peripheral hyperopia, and hyperopes had relative peripheral myopia. So that is the opposite kind of refractive error was seen in the periphery in both hyperopes and myopes. So this was again a study with almost 528 children. Then in other studies which were Chinese based, they again found peripheral hyperopia. But what we found is that there are myopic in Indian population, that myopic defocus was more common compared to hyperopic defocus. So before I conclude, I also would like to add that it can be challenging sometimes to do a peripheral refraction, whether it's on the machine or whether it's manually, with these spectacles on. And when we talk about peripheral hyperopic defocus, it is with the spectacle lenses or with the optical correction that we propose that there is a peripheral hyperopic defocus. So, and in such situations, it's very difficult sometimes, especially in high refractive errors, to get the peripheral refraction very accurately. So, with that in mind, yes, peripheral hyperopic defocus was postulated myopia progression. In our study, we found that myopic defocus was more common, and this lesser prevalence of hyperopic defocus in myopia patients raises the question whether this actually has a causative role in myopic progression in all the myopic children or only in a few selective children. And but since there is very less data available and we have very few patients who've been studied, and this is a retrospective study design, therefore these are some limitations in our study. Of course, we require larger samples and we need comparison between different types of refractive error. For example, there was a study which actually spoke about myopic defocus in hyperopes. So this is something that we have to look at. We have to compare and see if this kind of similar trend is seen in all refractive errors, or is it exclusively seen in myopic patients, is something that we need to explore and see. So some food for thought is, of course, that if all the defocus based treatments are actually based on the theory, and we have seen so many studies that these optical treatments actually work, then how do they work? Is it the change of depth of focus as what happens in ortho-K, that's working compared to the myopic defocus, or is there any other mechanism of action that has still not been explored? Is again the question which is in all our minds. So with this, I would like to conclude my presentation, and let's all continue to fight to beat myopia together. So I'll be open for questions and comments.
Thank you, Dr. Sumita. So it was a wonderful presentation, and we understand that checking the hyperopic defocus in these myopes who are progressing is very, very important. And I think this is the message which we want to convey to the practitioners that, checking the hyperopic defocus. And you showed us the ways, how we can check. And as you told, Dr. Chitani has a wonderful device which can be used for doing a peripheral retinoscopy. The LVPI has also come up with a helping agent where we can use this. So, any thoughts on this, Dr. Jetani?
No, I just wanted to ask Sumita if the patients that you studied and they were not having peripheral hyperopia, but if they were prescribed glasses, do the glasses still work?
Yes, I mean, so that's exact. Since it's a retrospective study design, we had a chance to go back and see how their myopia control was, and what we found was that those who did not have a defocus, a hyperopic defocus, also the glasses seem to have worked. So that's why we put up that question as to, is there any other mechanism that these optical treatments work, and does it actually, even if there is a myopic defocus, do these glasses further increase the myopic defocus, and is that how they work? So these were the questions that were actually in our mind. What has been your experience, Dr. Jetani, with respect to peripheral?
I do think so I do think that even if they have peripheral myopic defocus, once you give the glasses still work. So the
Yes.
working theory that it's not published, so it is totally just a hypothesis that I have thought, which is that in some way there was some hyperopic defocus, which when we measure it is not there, and whatever that is, that gets improved with the glasses. So
Yeah.
obviously, we should be able to measure the hyperopic defocus to see that it is hyperopic defocus. But somehow the glasses do work. So at the end of the day, there is very little evidence that glasses should not be given. The glasses do work, and
Yes.
so we do measure the peripheral refraction, but we don't keep a cutoff that if the refraction is only those patients who have a hyperopic refraction, peripheral hyperopic refraction would be given glasses. So
Yes.
we do give the glasses, we do measure, but we still tell them that whether there is peripheral hyperopic defocus, it would still work. I think once we have more devices which can map out everything,
Yes.
we can say that maybe in peripheral hyperopia it would work better, but it still works in most of the cases.
Yeah, even though you don't measure it, and if you just prescribe it, you would see that it has slowed down anyway, a lot of times.
Yes.
Yes.
Dr. Smita, I just want to ask, do you always measure the peripheral refraction with the distance correction in situ, or without, even
No,
before
see,
giving the
we've
distance correction?
tried both. We actually find it very challenging. That's what I was telling the audience, that we find it very challenging to measure it with. See, ideally speaking, it should be measured with the correction in place, and but we find it very challenging to get the reading when we do it with the glasses. So only in a selective few patients we were able to get it with the glasses. All others we had to take off the glasses. If not, the ARR, the peripheral refractor, does not pick up the reading.
What I
So
feel
there's
is,
no.
even without the peripheral, even without the distance correction in situ, we can always see the relative difference between the primary reading and the reading in the peripherals, isn't it? So
Yes,
we'll
yes.
still get the difference. Yeah.
Yes. So my question is that perhaps it is because of this that we checked with the glasses. I mean, without the glasses, and maybe with the glasses, the hyperopic defocus would be induced, which is not being, which we are not able to measure currently with the devices. So maybe that is the answer to the question as to how these work.
But I think with glasses, it is much easier to measure when you use a retinoscopy, like the device that we have made or the LVP's device. With glasses also you can measure, because the whole purpose is that it is more of a free space. With with open field autorefractor, the kid has to still put the face into that, although it is a transparent screen, much more accurate, but not very dynamic.
Yes, agreed.
Agreed. I would also invite other panelists. Dr. Arun, do you have any thoughts on this? How do you measure your peripheral refraction?
I don't have a peripheral refractor, so I am doing it manually only by asking the child to fixate on targets at 30 degrees apart. But as the other panelists have said, even I have seen that even when the peripheral refraction doesn't show an hyperopic defocus, still the glasses are working. So that is my observation also. And I have been using it for most of the children.
Thank you. Dr. Aarti, do you have anything else? Your practical opinion, how do you do peripheral refraction in your setup?
Frankly, Dr. Mang, just like the other speakers were saying, practically, I think when it's a busy day,
I almost skip it for all patients, knowing that irrespective of what I'm going to find, I'm going to still advise, myopic peripheral defocus glasses. When it's a light day, then yes, more for interest sake and to see what's actually happening, I do it, but I do it manually. I don't have an open AR. And I think another point here is that because there is no cutoff of how much peripheral defocus is really valid, and nor do we have, glasses that are customized according to that. So I think it's still more of a research concept and not as valid in a clinical setup currently, I feel.
So I would also want to ask Dr. Ipsita, please shower some light. How do you do it at your setup?
See, the same thing that Dr. Aarti mentioned. A, it is really very difficult. And B, I would like to emphasize that the whole concept of controlling myopia is at a very less age when you intuitively, with excellent elongation, you are trying to predict something. So you would probably assume the child is somewhere between 5 or 6 years or even. So a child to be so much of cooperate, to have so much. So if you want to tackle childhood myopia at the very beginning, so the whole purpose of controlling myopia is low myopia at a very young age. You control and you see the result in axial length elongation. You can see the retardation or the limited progression. So in that age group, with the children who are actually myope, like they have this kind of lifestyle, it's a lifestyle issue. So they are a little bit more urbanized and they're more a bit. They might be a little bit more. Not cooperative, I would not say. Maybe they are jumping around and they are not very cooperative only. Finally, I have to use a word for a peripheral refraction because they are scared to sit in an auto ref also, or they do not keep their mind out there, and then to take another 2 minutes of your time with that. So in our center we do not have the open auto refractometer, so obviously we do not do that. And I tried doing the one with Dr. Jethani's thing, but I tried in the sense our optometrists, but very frankly speaking, most of them gave up. So I do not rely on the peripheral hyperopia. More often, it's the axial elongation and the prediction and the use that counts to finally restrict the myopia.
Yes. So I think
we
Dr.
can take some questions from the chat box also, man.
Yes. So there has been a question which is saying that I think we have discussed this question that we are prescribing glasses. I think all the panelists agree upon this thing. And is this also holds true in adult population in all age groups? So does presbyopic, myopic, does it hold true? Does anybody has an experience giving these such classes for an adult age group?
No, I think for adult age group, the concept is that the eyeball size is increasing because of peripheral hyperopia. So presbyopia has a different kind of mechanism. I don't think presbyopia works at the level of axial length. Presbyopia is more of a physiological concept, and myopic progression is more of an anatomical concept on the basis that there is a anatomical elongation of axial length. And bulk of what we would be discussing would be to prevent myopia progression, axial elongation. We won't be much into lenticular and curvature myopia. So the thing is that this really does not apply in eyes which are not growing. So this is a concept which was given by Earl Smith, published. Multiple articles have been published on chickens, and they have done some work on optical defocus also. But that is mainly to show that the size of eyeball is growing because of peripheral hyperopic refraction. Not that, once the adulthood is achieved, there would be any changes further into axial growth. So presbyopia and these are at different levels.
Yes, I also agree. Also, the concept of index myopia is there, preferably in presbyopes. We never know. Sir, I have one question. So, I do measure peripheral hyperopia in few of my patients. Obviously, not on a busy day. I could not. So, when I find peripheral hyperopia, I say that myopia control glasses are definitely recommend it for you. And if it is not there, I give it as a choice in addition to the atropine, low dose atropine. So, do you think this approach has any more correction to do it, or anything you would like to advise?
No, I think that's fine. I mean, that's fine because, once there is, so there is a definitive clinical evidence with you that there is peripheral hyperopia. And so you are trying to give it to the patient that, we have measured your hyperopic, we have measured your peripheral refraction. And since it is hyperopic, we are pretty sure that glasses will work. And as the evidence will come, we would be more and more sure that peripheral hyperopia has a role or doesn't have a role, or somehow, as Dr. Sumita rightly pointed out, once the patient wears the glasses, there may be some hyperopic, there may be some peripheral hyperopic refraction that may be inducing myopia in the kid. So that may be the reason that once you give glasses, it is happening. And once you give a myopic defocus lenses, they may help in slowing down the progression of myopia. So you are perfectly, I think you have summed it up nicely for all of us that, we can also tell the patient that since it is there, we can give it to you with more confidence. And since it is not there, maybe it's a choice.
Yes. So now we are all talking about myopia control glasses, and we have studied that there is a peripheral defocus which is there. So I would like to request my co-moderator, Dr. Ketki, to please introduce our next speaker. He will be telling us about the myopia control glasses.
Yeah, I request Dr. Kalpit Shah to give us some valuable inputs on glasses for myopia control. I'll request him to, yeah, he's sharing the slides. Thank you.
Yeah, am I audible?
Yes, sir, you're audible and your slides are visible.
Okay, fine. So as we were discussing about that glasses for the peripheral myopic defocus, so there are different glasses available to progress the myopia. First, we have to understand that just for that who are not very much known or aware about that myopic defocus, hyperopic defocus, just to understand the basic pathophysiology. In the first slide, you can see when there is an uncorrected myopia, the rays coming from the infinity are focusing in front of the retina, but still in the peripheral part, the rays are focusing behind the retina. So what happens that as we have understood the normal hematropization process, when the rays are focusing behind the retina, then the eye or the retina gets certain stimulation that it has to grow so that the axial length elongate and the rays will focus exactly on the retina. So when there is a peripheral, like we can see the rays are focusing behind the retina gets constant stimulation to increase the axial length so that the rays will focus exactly on the retina. So here, when there is uncorrected myopia, there is a constant stimulation that eye has to grow so that the rays will focus exactly on the retina. But now what happens when we give the single vision lens? When we correct the glasses with the concave glasses, then the central rays coming from the infinity will focus exactly on the retina. But still, in the peripheral part, you can see the rays are focusing behind the retina. So still, the retina gets constant stimulation that eye has to grow so that these peripheral rays will also focus exactly on the retina. So in the process of this, the axial length constantly elongate. So even if we give the single vision, the normal conventional glasses for the myopia, the eye will constantly elongate, axial length increase, and the myopia will progress. So to overcome this problem, we have a different type of glasses available so that the peripheral rays, which you can see here, which are focusing behind the retina, by giving the hyperopic elements in the peripheral part of the glass, the peripheral rays will converge more. So instead of myopic defocus, instead of hyperopic defocus, the rays will focus in front of the retina so that the retina will not get more stimulation to increase the axial length. And in a way, we can decrease or we can stop the progression of the myopia. So this is the normal like understanding by giving the different type of defocus glasses. We have a different type of defocus glasses, like Hoya has come with the MioSmart, and it is based on the technology that is called the DIMS, that is a defocus integrate multiple segment. The Essilor has come with the stylus, and it is based on the whole technology, which is called as a highly spherical lenslet target technology. Zeiss has come with a different innovative technology, that is MyoCare, and based on the CARE technology, that is a cylindrical annular refractive elements. But the different part for the Zeiss MyoCare, that the back surface have a clear focus design, so that when the child is looking from the Zeiss MyoCare lens from the peripheral part of the glass, he will constantly have a clear vision. And the same like the vertically progressing lens, just like a presbyopic patient, Nova has come with the different idea that if we give the horizontally progressive addition lens, then also it can decrease the hyperopic defocus. But as we understood in the previous talk, that first we have to measure the peripheral refraction. If the peripheral hyperopic diffraction is more than 0.75 compared to the central refraction, then there would be a we can say we can clearly prescribe the defocus glass. As we already discussed, even in the myopic defocus, we can give the glasses and we are seeing the result. But to confirm or to give confidently the glasses, the peripheral refraction should be more than 0.75 than the central part. But when there is an accommodative leg, then there is a more like our way to give the glasses, that is a progressive addition lens or the bifocal glasses. And same like the glasses, we can give the contact lens that is like a defocus contact lens, that is a my side. Even multifocal contact lens we can also prescribe when there is an accommodative leg. So, like to understand the Hoya MioSmart, you can see the in this figure, the central part that is almost 9.4 millimeter, that is a clear zone, and that is for the single vision lens, that is for the central rays. Now, in the peripheral parts, there are certain elements, so which has a almost plus 3.5 diopter of elements, and this will give or this will convert the peripheral rays more, so that the rays will focus in front of the retina, which will halt or which will decrease the progression of the axial length. So this is the Hoya MioSmart, that is a DIMS technology. As you all know, in the peripheral part, the different elements, the pupillary area would have a 50% of that area. So 50% area is for the single vision lens or for the central rays, and the 50% of that area of the pupil will be covered by that hyperopic elements, which will decrease the peripheral refraction. Like when we prescribe the defocus glass, we have to be very selective. The binocular IPD could be different and the monocular IPD could be different. So we have to make the glasses according to the monocular IPD. First, we ask the parents to select the frame and tell the parents to come with that child with that frame, so that we ask the child to wear the frame, and then we mark the horizontal as well as vertical centration of the pupil. Because normally when we write the PD, it is mainly horizontal. For the vertical measurement, we have to do manually. So the height is also important, which should bisect exactly from the center of the pupil. And normally we prescribe the frame for the pediatric patient, which is smaller size. But when we prescribe the defocus glass, we have to prescribe the frame which is little larger one. Now the Essilor has come with the stylus technology, and that is based on that whole technology that is called the highly spherical lenslet target. Here, instead of the elements, they have rings, and total there are 11 rings, and each rings has a power which is decreasing, which is increasing from the center to the periphery. So in the peripheral part, we want to have a more plus power, which will converge the peripheral rays more, while in the central area, which we need the less plus power. So here, instead of the fixed elements, the power of these hyperopic elements will increase from the center to the periphery. So it is same like a progressive lens, but the power, the elements would be increasing in a ring manner. And the advantage of giving a SLR, it will produce a volume of myopic defocus. Same like the EDOF lens, it will induce the volume of myopic defocus. So when the child is looking from the peripheral part of the glass, still he would have a clear vision. Now, same like that we were discussing about the vertical progressive lens. Instead of that, if we give the progressive lens in a horizontal manner from the center to right and left, we increase the power, the plus power. It will also reduce the peripheral hyperopic refraction. Now, the JICE has come with the two innovative technology, that is a cylindrical annular refractive elements, and the back surface is with the clear focus design. To understand the JICE myocare lens, we have to understand that ortho-K lens technology, and it is a combination of ortho-K contact lens as well as the multifocal contact lens. So in ortho-K contact lens, we know the basic treatment or basic theory for ortho-K lens, that it will flatten the central part and little bit induce the stiffening in the mid peripheral part. So that will cover the peripheral hyperopic refraction. And the soft multifocal contact lens has a increasing power from center to periphery in a hyperopic manner. So when we combine these two, that is basically JICE myocare lens. So the pillar one, that is a front surface, that is providing the care technology, what we were discussing, that is a cylindrical annular refractive elements. And on the back surface, that is a pillar two, that is optimized to provide the clear focus design, so that when the child is looking even from the peripheral part of the glass, he will not have any blurring of vision, and still he will enjoy the clear vision even if he looking from the peripheral part of the glasses. So, and the Myocare is available in two variants, like a softer version and the harder version, and that we can prescribe according to the age group. Like earlier age, we can give the harder version, and the later age we can give the softer version. So just to summarize, like we can give the glasses as we already discussed, either the defocus glass or the progressive lens, that bifocal lens. First, we have to measure the peripheral refraction and the accommodative leg, and then we have to decide which glass we have to prescribe. Over to you.
Thank you, Dr. Kalpit, for the crisp overview of the glasses that are available. I also want to ask you a question.
Yes.
After we prescribe the glasses, have you come across children, especially the older ones, with any symptomatic contrast loss or any vision problems that they're having for peripheral vision, especially?
Yeah, there is not much of the contrast loss, but of course they are telling like when they are looking from the peripheral part, then there will be little blurring of the vision or waviness of the vision. And that of course can occur because there are hyperopic elements in the periphery. But as to combat that, the JICE has come with that different technology, that is the clear focus design. So that even from the periphery, they will not have that much of the blurring of the vision.
Yes.
But of course, that intelligent child will tell that he has some problem with the peripheral part.
And the one who has the theory. Yes, sir. Yes, Dr. Arun.
I agree with that one, because I have at least two patients who were on Stellus that had to shift to Zeiss because they were extremely irritated with the poor peripheral vision. So definitely the comfort was more with the Zeiss lenses in the peripheral vision, and very sensitive children have this issue.
Also, I want to note give one point that the most common patient would come back with Lenskart or Titan Myo Care glasses, and they would say, yes, I have been using a defocus glass, and they would be progressing nicely with the Lenskart or the Titan glasses. So I do mention to them that please buy it from an ophthalmological setting, not from any eye hospital, like particularly my hospital, but any eye hospital which would provide you the right kind of options, if at all.
Right. And also the centration is extremely important in these lenses. If little bit of decentered these lenses are there, children will be extremely unhappy with the quality of vision.
Any panelists would like to add about the choices, if you have any very
In our center, we don't give progressive addition lenses for myopia control. We don't give it anymore. We only stick on to these three kinds of lenses: the CARE and Stellest and your Hoya lenses. So this is what we give. We don't go to progressive lenses anymore.
No,
I just want to add one. Sorry.
No, please carry on. Please carry on.
I was just saying another practical point that I've found in clinic as a positive point for Zeiss is that children who have a combined total power of less than 6, they do have the option of stock lenses, which cost half of what the lens would otherwise. So when I have a child whose power is not exceeding 6, then it becomes easier to counsel them for a Zeiss, which would only cost somewhere around 8,000 as opposed to 60,000. Then no other lens gives that option of having a stock lens at a lower power. Rest, all of them will cost the same, around 16 to 17,000. So that becomes an important factor in convincing these patients, because financial cost is a major issue with these glasses.
It is, I think, till plus 4, till 4 now. Not 6, but till 4.
4 with cylinder, sir.
Yeah, 4 with cylinder.
4 with cylinder less than 2. It comes to around 7,500. So financially, that's I think the major hurdle we are facing in adopting this technology. So that's why low-dose atropine is more popular than glasses, mainly because of the financial issues.
Yeah, just I wanted to ask, like, anybody has come across, like, they are claiming that we can replace if the number is increasing more, like earlier that Essilor has come with that. But honestly, we don't have any idea or any incidents that we need to replace or that. But anyone has come across this situation?
Yes, sir. Yes, sir. I have replaced it. They have replaced it for us.
Yes, we have also replaced it.
Sir, I have also come across that situation once or twice. They have replaced.
Okay.
Yeah, within 9 months, they claim that they would be replacing it.
No, they have
The
replaced it.
change has to be more than 0.5 in the sphere.
Yes.
Placement is never an issue.
So you are adding some points, Dr. Jitani.
No, I was just trying to continue the line that you had talked about the glasses which come from Lenskart and outlets which are apart from these three companies. If you see their glass, no, it is just a coating. If they come back to you, what you have to do is you have to take the glass and put the light. Those lenslets will not be having a hyperopic power. So if they don't have a hyperopic power, it is very difficult that they would be leading to any significant improvement or significant reduction in axial length progression.
Yeah.
I think most of us have got those patients because, all of us have been practicing myopia. And what has happened is when you tell the patient about the cost, they go and get these glasses from Lenskart. Especially this is true for Lenskart. Rest of the optical shops, they will prescribe the branded ones. It is only the Lenskart outlets which prescribe some local or some Chinese company. And the glasses, their myopia control glasses actually do not make a difference. Well, some of the patients, the number does not progress, but most of them does progress.
Dr. Jethani, any experience with anisometropia? Have you given for with axial length elongation proven, and you've given that and you've seen results? Hello.
Results. I'm sorry, I didn't get the question. And I think there's some network issue. Yeah. It's my network issue.
It works, madam.
Can you repeat the question, please?
It works.
I was asking your experience with anisometropia cases with proven axial elongation. So you can see that the rate of axial elongation in the longer eye is more than the other eye. And then you recommend myopia control glasses and you see the improvement. Have you had such clinical cases, documented ones?
Yes, madam. I have documented ones where definitely it works even in isometropia. Yes.
Sir, I had a question to ask about Zeiss Myocare S. I don't have experience using Myocare S yet, but I have used plenty of Myocare. And recently, when I wanted to give an older child Myocare S, they found it quite hard to get it in the market. I just had a query regarding, do you use age as really a cutoff on who to give Myocare S to, or is, is it the sort of rate of progression that helps you decide who to give Myocare S to and who to give Myocare to? Any experience with that, any of the panelists?
No, normally we prescribe the normal conventional that Myocare, but we have not prescribed the softer version. Jethani?
You're muted, Dr. Jitendra. You're muted.
So Myocare S, as I understand, probably that has got a smaller central zone.
So
7
that has a
millimeters.
larger central zone, but a softer plus. So it has a lesser plus, and the central zone is actually 9 mm as opposed to the 7 mm in the Myocare. So if they consider it a softer design with the rationale that older children who may not be progressing that fast,
Much faster, yes.
we can do away with the Myocare S. But I don't have any experience.
Neither. No, I don't have much experience with that.
So I have a question to the panelist, and this is a very controversial question because the patient will come back to us and they'll say, "Ki, Doctor Saab, all these options are available. You only tell me which one to go for." So anybody has any workaround a way that how do you counsel your patients, or do you have any pathway to follow that if some things are there, you'll prefer a particular brand or different ways? So please, anyone. Dr. Arun, please.
Yeah, I think the first criteria is, as Dr. Aarti said, this the financial this thing. If the power is 4 with less than 4 and with less than 2 cylinder, obviously my choice is Zeiss because financially most people accept that one. But if it is a higher power, then not much of difference. Probably it is just explain the pros and cons, so they take a call on that.
But we have also started getting evidence now. I think maybe a year ago, I found it very hard to answer that question. And I would only base my preference on whether the stock lens can be given or not. Otherwise, I would leave the choice to the parent. But now, like recently, Dr. Sandra Ganesh had shared one of her articles on the group. And that's a huge number of patients, almost, I think, 900 patients. And they have come up with superiority for the Halt lenses. I think there was a study by the Ames group as well with smaller numbers, but again, the Halt came out to be superior. So now I've started saying that we are now starting to get scientific evidence that the Halt may be slightly better compared to the other glasses. So in children where I feel the affordability is not an issue and the parents are, a little more sort of keen and they're not really bound down by the financials of it, and the number is even below 4 in sphere and 2 sil, then I have a slight preference towards Stellus Tessalon now. And I use these studies as, like a reason for that. Otherwise, I think stock lenses are still the ones that are mostly preferred if children are in that range.
Dr. Anthony, you would like to add something?
Yeah, the same thing. No, the same thing. I also tell the patients that we don't actually have a clear-cut evidence as to which is better or worse. So it is up to you to decide. That is what I offer the patients. Just now we are coming across these articles where we see the Halt lenses are better, but previously this was the standard word that I used to tell them. Even between LDA and these lenses, many people ask us, "You tell me what I should use, whether I should use atropine or whether I should use this." So I tell them I'll prefer that you do use the defocus lenses because using these drops, again and again regularly, compliance is always an issue. So better go for lenses. That is what I say. But I'll always leave it to the patients to decide because how much they'll be able to pay, they can decide. I also would like to ask people about, is there a cutoff that you keep for ametropic amblyopia patients with myopia, with those with visual acuity of less than 612 in both the eyes, with ametropic amblyopia? Do you prescribe these defocus lenses to them as well? because we don't know the effect of these defocus this in the amblyopia treatment and all as such. And what about patients with squint? Mostly, if they have a large manifest, which is often manifest, we generally don't prescribe these lenses. Do you guys have any other take on it?
Sir, I think even in very well-controlled intermittent exotropia, I once tried with a lot of courage a myopia control lens in that, but the intermittent exotropia worsened and I had to then take the child off the glasses, which can be something very hard to explain to parents, and considering the cost of the glasses, that would really make them unhappy. So now, even if it's a very well-controlled intermittent exotropia, I don't use these glasses at all.
So I
May I
would,
just add a point there? Just an interesting, take on that is that people often seldom look through the center of that. Am I audible?
Yes,
yes,
yes.
yes, yes. Please go ahead.
Yeah. Yeah, so people seldom look through the exact optical center of the glass, right? They seldom use the central 1 centimeter area. It's usually the other areas that people with glasses often use. So, would it really matter if they have exotropia? Is one question that I always had in mind. So maybe a squint does not matter as much as we think it does is what I think, but I don't know. I don't know how to validate that point.
So, yes, I do agree that we rarely use the central part of the glasses. So, I would be able to tell you my experience. What I do is I always keep squint at the first priority. I always keep vision at the first priority, and later the myopia control. So, what I feel is that controlling myopia is important, but not at the cost of vision, not at the cost of amblyopia. So I always tell them if they're the first time wearer. So all these patients, what we are discussing, usually these children would not be having any glasses. So the first time glasses would always be a normal glass. I also do not tell them to go for some filter glasses or any high-end glasses. I tell them just buy a very, 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 very common normal lens, because once the child starts wearing it, the child will also have some wear and tear, and the parents will not have so much of financial burden on changing the lenses. So changing the lenses, I say that these lenses, they do have a life and it will go for somewhere around 2 to 3 months only. You'll have to change it. And at the follow-up, I do have a option of, giving and fine-tuning the refractive error of the child. So then onwards, I do prefer when the vision is not at stake, then I prefer myopia control glasses. So I do not tell them only about in the first visit, even if their eyes are progressing. I think Dr. Jetani would agree with me. If anything to add, sir, please.
No, no, I completely agree. I think we should talk about the visual acuity first, and only when there is actual elongation or progression we think about these glasses. But see, so if what the point Dr. Sumita raised was that when we seldom look through the glasses, I think both the things validate themselves. See, if there is an intermittent squint, that may worsen because the child may not be having an overall visual field, and in intermittent exos they may worsen if they don't have a proper peripheral fusional reflexes, and they are not able to bring the eye back. But I think in constant exo or in constant ESO, it will not make much of a difference because, whichever eye is fixing, that will be looking from the center only. So technically, what Dr. Anthony also asked was that, whether in amblyopes, in ametropic amblyopes, whether we can give these glasses. I have not really given. I'm just again thinking about it that, amblyopia is purely foveal or parafoveal part, and this is definitely paramacular or around outside 20 degrees. So 20-25 degrees outside, I don't think it will make much of a difference if there is a myopia progression with ametropic amblyopia. If it is there, I think this should work technically. anybody else if they have anything.
Sir, I have a point. When I see the patient for the first time, I actually prime them that in the future you may need a 16 or 17,000 glass and see the progression. And every time the child comes, I warn them that if you don't adhere to the lifestyle modifications, future you would be needing that glass. So by the time on the third visit or the second visit they come, they know that they have to buy a glass if they don't adhere. And most of them are mentally prepared for buying a glass for that much price. And so I have this controversial thing to say, but I do prefer Halt more over the original Zeiss lenses because I've seen a little more progression with the Zeiss glasses than I've seen with Halt.
I think if you have,
think,
if you're doing the biometry, like your axial length and the keratometry, even if you don't have the Myopia Master or any software, you can do that online BHY website where you can show the graph. You can tell the patient, okay, this is how it is progressing, and this is the effect of using the glasses. This is the effect of using the atropine drops. So I think in the first visit itself, you can just show them so that they are primed for the glasses on the next visit.
So, Dr. Jethani said that baseline axial length, when do you recommend that we should do for all myopes, like 5 years or 6 years when they've come? Do you do a baseline axial length for everybody?
Yes. In fact, I do baseline for for kids who are pre-myopic. Like even if they are little bit on the hyperopic side, they're the family history, or they have withdrawal astigmatism, and those typical patients where you have -2 cylinder and a plus 0.5 or 0.75. I do axial length for those patients also, so that we have a baseline, and then we can find out and build upon it.
And then repeat every 4 months or 6 months, depending upon the age profile.
Yes.
And supposing
Yes.
supposing the child is 10 years, towards 10 years, or maybe there is a slight growth spurt that you see, and you also correlate that there has been an axial elongation. Do you think it's more of the growth spurt than the childhood myopia per se for near work elongation? Do you keep that in mind?
Yeah, so growth spurts will so all the patients will have whenever you are doing working in myopia, there will be times when your all the myopia control will go haywire for a year or so. Whenever this kind of growth spurt come, it may come at 9, 10, 11, sometimes at 11 and a half years also. So suddenly, they will come out of all the myopia control things and they will progress. So that happens. But, you just try to tell the patient that has the height increased in last 6 months or 1 year.
No, so my question is, do you stall your decision of giving myopia control glasses then? Do you wait for another 4 months, or you even you go ahead with your decision of giving myopia control glasses?
So most of the times my practice is that I always try to suggest the patient that this is there and this is progressing and we should do this. And then I let them come up that what they want out of the available things. As Dr. Ketki rightly said, the moment first time patient walks into the clinic, I sort of tell them that, myopia is there, this may progress, and these are the options. And then we take it from there every time we take it from there, something for this. And if they feel that we do tell them that this is the growth spurt and it may not come back again. But I think most of the patients are very much alarmed once you tell them everything, no? They want that something should be done. So most of the times I will have to escalate the dose of atropine. Most of the times what happens is we escalate the dose, knowing well that this spurt may not come back, and it will be more like this progressive myopia will slow down eventually. But then sometimes patients are very much because we only told them 2 years back that the myopia is progressing, so now they are very much tuned to it that doctor, this is not working.
I have a question, sir. In my OPD, I do axial lens for all age groups, say about till 17 also. Sometimes I've done for the newly diagnosed myopes. So I want to ask about the axial length prolongation that I see even after 15 years, 16 years. I've consistently done their axial lens, and I do see that there's a refractive error change happening in sometimes in an 18-year-old also. So do you recommend some kind of treatment? Because I'm seeing that there is a change and I cannot just overlook that. And sometimes with a warning, I start the low dose atropine even in later age groups. Do you think that there should be some modification to this practice? Or
The only issue with starting low-dose atropine at an older age is that they may come back to you with complaints of photophobia, and it is more common once the age is more than 15 years. But if it is well tolerated, obviously the axial length elongation is going on, and we have to understand that once it stops and the myopia progression stops, only then we can, take them off atropine. So a lot of times what happens is that these patients they do come back and say that there's a problem with near work. Even the routine atropine patients whom you are putting atropine at 13 or 14 years, once they grow up, they come back saying that, so in some of the patients, we have given them even, peripheral add-on lenses. We have added 1.5 to their glasses, progressive lenses.
I think nowadays it's too much of stress between the standards 10th, 11th, 12th,
Because
excessive competition. So that has led to excessive near work and digital eye strain, and most of the students are attending online classes, online coaching. So I think that has increased the amount of near work and the stress on this thing, and probably that might be the reason why we are seeing progress even in at 19, 20, 21 also.
yes. Dr. Mayank, would you like to introduce the next speaker if there are no more questions?
Yeah, I think we had a great discussion on the available technology, the halt, the DIMS, the care, and I would like to introduce now our next speaker, Dr. Amit Gupta, a very nice friend and a very generous, I would say, a senior of mine. He would be telling us about newer glasses for myopia control. So over to you, Dr. Amit, please. So you're muted, sir. Your slides are visible. So I would use this time to introduce him further. He's a consultant at Kapilai Hospital at Ambala. He has done his fellowship from LB Prasad Eye Institute, and also he's very much present in all the pediatric ophthalmology forums. Sir, please. Uh, you're not audible, sir.
Yeah, now is it audible?
Yes, sir.
So thank you, Mayank, for the generous introduction. So now I'll be discussing about the newer classes that we have or will have in times to come for progressive myopia for our practices. So what is the basic need? Why do we need these newer glasses? So we come across some patients where we are trying these glasses and we have failure with these glasses. Inadequate response, we very commonly come across patients who are still progressing at a rate more than 0.5 to 0.75 diopters, even with the use of whether low dose atropine or we are using some kind of progressive glasses, and still they are progressing, or these myopic glasses. So we are concerned what would be the end result. So we are trying to curtail the end result of myopia progression. So patients who are fast progressors, we still don't have answers for those patients. And younger the age, more are the myopia years. I call this myopia. So the time the child spent with this myopia, they are going to progress all those years, and the end point would be much higher. So we need an intervention for these patients. So this was a study which has been done by the Essilor group regarding Stellest. This is the Stellest 2.0, where which they called as Halt Max compared to the Halt which we earlier have. So this study was done between November 23 to January 25 as a randomized controlled trial, double masked contralateral crossover, where 50 patients were enrolled and 25 were put in either arm. In the first arm, halt was given in the right eye and halt max in the left eye, and opposite was done in the other arm. And then these same patients were crossed over in the second 6 months, where halt max was given in the right eye and halt in the left eye in the second phase, and halt in the right eye and halt max in the left eye in the second phase of the study. So basically they were following up them for their biometry with a lens star, wavefront aberrometry, and a non-cycloplegic refraction, which was done for all these patients, and they followed up all these patients. So the modifications which they have done in these glasses is the central optical zone they have reduced further to around 7.58 millimeters, and they have increased the hyperopia of the central lenslets to a much higher degree, so that they have a higher amount of volume of myopic defocus. Earlier the volume of myopic defocus was close to the tune of 0.75 millimeters. In the previous halt lenses this has doubled to 1.6 millimeters, and the amount of myopia which was induced, myopic defocus which was induced with the use of these glasses, earlier it was 1.3, so it has doubled to 2.6 millimeters. So this hyperopic segments being increased and bringing it closer had increased the amount of volume of defocus and their peripheral myopia which is induced by these glasses. So if we look at the results have just been published. So if we look at the results, so if we look at halt max, so the yellow one are the halt max and the greener ones are the halt previous halt classes. So there was a significant slowing of progression of myopia with the use of halt max in the first phase, and once the eyes were switched over to halt max, there was a significant slowing compared to halt which was used earlier. So halt max had a significantly slower progression of myopia compared to halt classes. And if we look at the cumulative effect of halt versus halt max, so halt classes had a progression of 0.228 millimeters of axial length progression in 1 year, compared to halt max it was 0.121. So there was a 0.107 reduction of progression of axial length with the use of halt max. So there was a statistically significant difference. And if we look at it in terms of myopia progression, so there was 0.21 diopter slowing of progression of myopia at the end of 1 year with the use of halt max. And around 75% of patients, they had a slower axial length elongation with halt max compared to what was seen with halt lenses. And these halt max lenses were significantly better in faster progressors, and also in patients where halt was not working that well, halt max was faring much better compared to the halt lenses. The halt max was faring better. So if we look at then the group did a subgroup analysis in terms of what are factors, what was faring better. So once the So younger the age, the halt max lenses, they were faring far better compared to halt lenses. As the age kept on increasing, the difference in terms of use of these glasses, the axial length progression the effect tended to be lesser. So younger the patient, these lenses would be far better. So we might have an option in times to come where these lenses we will be using according to age as well. So we might prefer halt max. Though these results are only 1 year results, we need to wait for long-term results of these patients over a period of time, and this was a very small subgroup which they have studied. So this was one very interesting article which has recently been published by Schwestag. It's a Swedish group where they have looked at, they covered parts of the pupil and they looked at which particular area was responsible for maximum progression of myopia. So there was a perimacular area, perifoveal area of 6 to 10 degrees, which was the most responsible. So they called it the retinal sweet spot for myopia treatment. So precisely that's how we understand that these glasses, the area has been constantly being coming toward the optical zone is being decreasing. And similarly has been done with the MioSmart IQ. This results, 6 months results of this have just been presented in Asia Arvo on 6th of February this year, where they have looked at what exactly is happening. So they have done they have an extended zone, a powerful zone, and activated zone. So what exactly they call by this? So activated, so they have brought the optical zone to 8.5 millimeter. Earlier it was around 9.5. So they have brought it even a millimeter further inside. They call it powerful because they have, instead of 3.5 diopter lenslets, now they have incorporated 4.5 diopter lenslets. So they they have basically thought that more the amount of myopic defocus that would be induced, that would make the lens even more powerful. And they have extended the lenslets. Earlier the lenslets were up till 33 millimeters. Now they have extended it up to 41 millimeters. So we don't have the raw data of all this. So what they have written is no myopia progression on average at 6 months with minimal eye growth was seen in this particular subgroup, and it was twice as effective as the previous design. So if we compare with the previous design, so they brought it to 41 millimeters. They brought in much, the optical zone has been decreased, and the power of hyperopic segments they have increased to 4.5 diopters. So this was one very interesting article where they looked at comparing the effect of peripheral image quality and vision with the use of these glasses. So here what they did was they measured the relative peripheral refraction, their peripheral vision, and they checked for the point spread function with all these glasses. So basically they were comparing the Stellest and the Myosmart with and a MySight. So they looked at these results and they found that with the use of wavefront aberrometry, there was not much of relative peripheral refraction which was induced with the use of Stellest and Myosmart glasses. So how exactly these glasses are really working? So they looked at the point spread function of these glasses, and there was a significant increase in the point spread function which was seen with the use of these glasses. So actually these glasses probably are, so ultimately what they conclude is probably these glasses are working on a contrast theory. The contrast for lower spatial frequencies is decreasing. That is probably the reason these glasses are working. And if we look at, there are now various articles which look at the contrast theory as well. We have had accommodative theory and other theories. And precisely what Dr. Sumita was saying earlier, that probably the patients who are having myopic defocus, there also these glasses are working. So probably we have an answer in the contrast theory. So a lot of patients, so earlier Bornholm disease was the one where they looked at the opsin gene mutations were there. In normal patients also who don't have a genetic mutation otherwise, they have an opsin gene polymorphism which is there, which leads to a reduced photopigment in the cones, leading to an inefficient absorption of light, leading to a reduced stimulation of bipolar cells. So each cone stimulates two bipolar cells, both on and off segment, and if there is any instability or uh, there's a difference in terms of stimulation of these bipolar cells, that leads to a contrast alteration, and in the presence of a genetic and environmental factors, like if the patients are subjected to high contrast images in the form of laptops or printed material or tabs, they have a higher propensity to develop myopia, and a myopic progression can be much more. That is precisely what is the basis of this contrast theory. And based on this theory, we have now diffuser optics technology glasses, what we call as dots, which are currently not available in India, but available in a lot of other countries where they have a central optical zone, which is surrounded by these dots of high and low contrast, which leads to a contrast modulation, leading to a slowing of progression of myopia in the patients. So there have now we have DOTS 4-year results are also available. These results have been compared with the DIMS and HALT and CARE, and DOTS also fares significant almost symmetrically as compared to what we have as the results with DIMS and HALT. The results are almost similar with all these classes. 4 years results of DOTS are also available, which also conclude the same, that it leads to around 55 to 60% slowing of progression of myopia. So this was one very interesting article where they looked at whether there any association with pupil area and efficacy of peripheral defocus spectacle glasses. So they looked at they didn't really specify what exactly is the pupillary area. So they concluded by saying that the patients who have a lower pupillary size area, the choice of glasses really does not matter. But once the size of the pupillary area is more, Stellest, it significantly fares better compared to MioSmart glasses. So probably a point to be taken here is that probably we need to pay attention once we are seeing the patient first time in our clinic also, we need to pay attention to the pupillary size that might guide us what choice of glasses we can offer to our patients depending upon the pupillary size area. So summarizing, myopia progression is an evolving science. We need to have a risk assessment in all our patients, like looking at younger the patient, more are the chances of myopia progression, family history. So we'll offer something which would be much more aggressive. Ocular biometric parameters would be key to decide our management. Pupillary assessment, as I discussed in one of the articles, they have looked at the pupillary assessment as well. So treatment planning has to be customized looking at the patient. Thank you.
Wonderful presentation, Dr. Amit. Very, very important that you told us that, we have to see the pupils, and it becomes more important because when we are dipping low dose atropine, and now previously it was 0.01 and now 0.05. So pupil size is changing, and that may affect that what technology they are using of the myopia control classes. So that is a very, very good insight that you have told us. Dr. Ketki, what are your thoughts on this? Have you assessed pupil in such patients?
Well, no, on the regular routine OPD, I did not assess the pupillary size in terms of planning the treatment that I would be giving. But in older children where I'm starting 0.05 nowadays, at that time I do assess in follow-ups, and yes, there is some amount of dilatation that is there. As long as the patient doesn't speak about that, any complaints, I would not change any of my therapies based on the pupil size that I see in the clinics.
So I would open this question to all the panelists that we have these three major technologies, DIMS, HALT, and CARE. What are your strategies when these technologies they do not work? The child is having a progressive myopia, and it is progressing even on 0.05 with all the best of the lenses available, with all the environmental modifications which is there. So anything else which we are missing out here?
Genetic analysis is something that we should be looking at in our patients. So
Yes.
there's a good subset of patients where they have some genetic mutation which is contributing. So sometimes we
Yes.
tend to ignore that and subtract that from our evaluations.
Yes. So we have to go to our basics. We have to see that why this myopia is progressing, and is it something which is physiological, non-physiological? Is it something which structural changes are there? So very important. Dr. Ipsita, you have something to add here? Ma'am, you're muted.
Not really, but there, yes, we have all probably got one or two of this such types where nothing is working. In spite of the best effort, you keep seeing eggshell elongation. So definitely there are more unanswered questions in the future. But maybe in the last 1 year, we've got answers to many a question. So in the future, like Dr. Amit highlighted so many new points, we are going to assess more and more and get answers to them. I couldn't add anything more.
I had a question,
I have,
Dr. Amit. Sorry.
yeah.
Yeah.
So I actually just wanted to ask this question, and I think I might have asked this before. In ROP children, those who are lasered ROP, and we know that the mechanism of myopia is totally different in those kids. It's not just only and only due to the axial elongation. It is something else as well. So have you have anyone of have any positive experience in giving low dose atropine or myopia control classes in these children?
Can I take that?
Yes, sir.
So my experience in ROP has been that, bulk of the patients do progress, but they do progress in the first part of or first half of their childhood. Like, they typically will progress very fast for around 6 or 7 years of age, and then they don't progress much. So any patient who progresses who starts picking up glasses after that age, I have given atropine because in those small subset of patients they start behaving like the normal childhood myopia. Otherwise, they won't be behaving like them. They will pick up very fast and they will go to a plateau of -12, -10, or very high myopia. And then they will settle for that. And as you already mentioned, their axial length will be around 22, and it will not really match with the amount of myopia. And typically, they will have a K of more than 46. It can be up to 50 also, and ACD also will be very low, like 2.1 or 2.2. So uh, patients who do progress after an age of 8 or 9 years, I have tried out very small subset of patients. So normally we would not be thinking about these drugs for myopia control at the age of 4 years. Like in another patient, we may think of giving atropine at 5 years of age, but not really in ROP babies. But once they grow up and they start behaving like childhood myopia, there are some subset of patients who behave like typical childhood myopia children.
Sir, a follow-up question for the ROP patients. So when they do start acting like normal myopes and we can document that yes, the axial length is increasing at an abnormal pace, do you think that there is, if they are lasered as well, do you think that the peripheral defocus glasses would not be a good idea for them since they anyway have field restriction? Are you only restricting yourself to low dose atropine or in them, or have you also used peripheral defocus glasses for them in any of these ROP children?
Am I audible?
Yes, sir.
Okay.
Yes, sir.
Sorry, I couldn't hear the question. Really sorry. You were asking about
No problem, sir. I was asking the ROP children. So I was saying, sir, when they do start acting like normal myopes, and we can document that yes, the axial length progression is at a much faster rate than expected, then especially in the ones who are lasered and we already know that field is restricted, do you think that the peripheral defocus glasses are then a very bad option in them? Do you completely disregard those? Do you only use atropine, or do you think we can use defocus glasses also in these patients?
Honestly speaking, defocus glasses do work. I don't know whether it is actually, typically there are a lot of unanswered questions with defocus lenses. They do work even in absence of defocus, like hyperopic defocus. So I won't rule them out completely because sometimes, we would be lasering really peripheral part of retina, like zone 2 and anterior to zone 2 is like outside 60 to 70 degrees. So that won't be making much of a difference in progression. And if we have lasered them heavily, maybe the defocus lenses are totally out of question. But I think bulk of these patients, all those heavily lasered ones, normally would follow a typical pattern that they will progress till 6 or 7 years of age, very high myopes. And normally, so even these glasses are not even an option because they are above -12. So atropine definitely as a first line of treatment, but I won't completely rule out. But the experience is very very small. We don't have many children from ROP babies who have been lasered and who fall into this criteria. There are children, but not many.
And the children with pathological myopia, where they start with a -7 at the age of 3 and progress, and their parents also have history of a pathological myopia, would they benefit from any of these treatments, either low dose or the glasses? Sometimes they do have posterior staphylomas and uh, uh, difficult refraction also in them.
I think there has been some work done published in IGO. There's a study done from Ahmedabad probably. They have published it that it works in high myopes. I have not used it much, And so I don't know, but there is some evidence only from our country that it works in those high myopes also. There is an article in Indian Journal of Ophthalmology, probably from Moradabad. I don't remember. It was that I remember the title, but don't remember the year.
All right.
But since we don't have any other option, I don't think there is any harm in trying it out.
Yeah.
And I think we can always counsel the patients that, look, this is beyond the normal range of myopia. And it may not be as effective as it would in other, but at least there is something that we need to try, because these are the parents who are the most desperate.
Correct.
Dr. Mayank, you're muted.
Sorry. So I was saying that these patients were in the exclusion criteria list of the ATOM study. So actually, that is why there has been no answers. So usually, when we say that these low dose atropine will be working, or these maybe myopia control classes will be working, we do have to see about all the patients that they should not be having these pathological risk factors. And if present, what I say to the parents is that there is no proven record yet, but there is no harm in trying because the safety and the efficacy has been established in the normal children. So this would be my take on this.
Also, one more point I want to add, that most of the progresses that I am getting are mostly because of the lack of adherence to the lifestyle modification, especially the sunlight activities and bedtime reading or excessive near work. So maybe 1 out of 10 is that one kid who has done everything, including an outdoor time of 1 to 2 hours, and then has progressed and would be a younger child around 7-ish, who would progress no matter what I tell about the lifestyle modifications. And I do ask about the reading and everything, every aspect of his life that I would inquire, so that I know that it's not the therapy or the treatment that I'm giving, it's the lifestyle that is causing the problem. So in that 1%, I think yes, genetic testing, but would can somebody shed light about what kind of genes would be needed to study? That I would like to know, if at all that is valid in clinical practice.
I think we are a little bit away at this point of time to have a very relevant genetic study to find out that this particular genome would be responsible for these children. But I think the day is not far that we will get those particularly indicated ones that this patient is not responding, and maybe in the future we may get a genetic profile done before starting, and we may specifically tell them that, look, you have this particular SNP, and you would respond to atropine, and you would respond to glasses, and this guy may not respond to anything at all. But at this point of time, I think we are still, going on that path, but not we don't really have a specific answer to this.
Yes, sir. Thank you.
Sumita may tell us. They are doing a lot of work on genetic therapy.
I think we still don't have answers, sir, because the range of genes are too many, and as you said, we have not been able to pinpoint very few genes. Even the genetic studies which have been done elsewhere also have shown multiple genes. So I think we are yet to find answers on that aspect. I just wanted to add regarding the pathological and high myopia that Dr. Ketke was discussing. The Singapore population has a high proportion of high myopes, and they use intermediate and high dose atropine for the high myopes. However, the challenge is, of course, the pupillary dilatation, photophobia, and the near work issue that they have. But they seem to give photochromatic glasses and bifocals pretty much to all of these children who are on intermediate and high dose atropine. So that's one option, but that's something I have not explored personally. I've been a little, wary of giving high dose atropine and explaining the complications. But Dr. Mihir has also done a study on high dose atropine in high myopes, and he's found it more effective as compared to the low dose atropine.
Yeah.
Atropine is indeed dose dependent. Atropine has a dose dependent response. So if you increase the dose, obviously it is going to give you a better response, give and take about the rebound. But obviously, if you increase the dose, it is going to give you a better response. That is obviously taken. The only issues are, I think the issues of photophobia and near work also, it is like, if everybody starts giving atropine 1% as a recognized treatment for myopia, most of the schools, and it becomes a norm. So I think with Singapore, it has probably become a norm because they have understood that, this is the only way to go. So maybe when we started at using atropine, we were already having an option of low dose atropine. So we have started our journey from, they have sort of come from 1% and they are coming down.
Yes.
So for 0.01, we often use it as a double dose, especially when 0.05 was not available. We did use 0.01 as a double dose. In some of these patients where we've exhausted all options, they're on 0. Say suppose they're on 0.05 and on myopia control glass, and they're still not controlled. Have you tried a double dose of 0.05 as well? And how much pupil dilation do we see with that, or how much does it affect near work? Any experience with that, sir?
No, I don't have many patients on 0.05 twice a day. I just have maybe 2 or 3 patients in which we have given twice a day. But it definitely affects the pupil size and definitely affects the near work. So in those patients, we have given progressive add-on lenses also. We straight up tell them that, this is it. This will happen, and you can always use an add of +2 or something like that. But they are very small numbers. We have not thought of giving 1% anytime. So, hats off to Mihir that he could pull off the whole study.
Photophobia and near vision abnormalities I see more often with 0.05 in patients who are more than 8 years of age. So
Yeah.
this,
True,
yeah.
very true.
So this
Because once the age increases, it becomes difficult. The amplitude of accommodation is quite low then.
Yes, yes, yes.
So I think we are nearing of our talk, and it was a wonderful discussion. Dr. Jethani, we do have some sort of questions for the participants.
I think in the chat box there is a link shared from the admin regarding the MCQ questionnaire, which the registered delegates for the for the certification course have to fill to get the certificate. Even if they give 70% of the correct answers, they will be given the certificate. There are some questions. I think one question is from Dr. Shack on myopia child, more than 0.3 millimeter increase in axial length per 6 to 8 months. The glasses of choice, I think we myopia progression. So discuss about the glasses. If there are any other questions which are left, you can ask mine. No,
You're muted, Dr.
One question. Sorry. Can I ask one question on genetics, please?
Yes, please.
If we have a child who doesn't have any evidence of structural abnormality, so this question is coming from a patient that I just saw in the morning in the OPD. So it was a 4-year-old first time visit with a -11, -12. The FF and OCT, everything are fine. The fundus looks normal. The parents are both myopic, but low, -1, -2 of that category. Now, I wanted to know, is this patient a candidate for genetic analysis at this point in time, just by virtue of having a very high myopia at the age of 4, even in the absence of structural problems to be seen? Should I advise genetic test right now, or can we wait? What is the consensus on that?
So if I can answer this question, I though have a very limited experience, So what I would do is that there is something abnormal which is going on here. It's not very normal to have a -11 in a 4-year-old child. So something is wrong. So first we'll do the profiling of the whole eye. I would like to know the biometry, I would like to know the K, and I would like to know everything else. So once I have done profiling of the eye, I would like to also do the profiling of the whole child. So I would like to see whether there is any contributing history, any kind of heart defects, any kind of other morphology, anything which I can see on the limbs or any high arc palate, any lucet ears, any sort of this. So accordingly, we will be managing. But here, our first priority obviously would be that we'll have to correct the vision. And at these patients, we should also look at the lens once, because sometimes I have observed that these patients are having some sort of an index myopia, which is sometimes missed, and this is like something which is not very visible. So these might be the patients of those category pediatric cataract which are just progressed into and giving a number of -11, -13. I think my panelist would be able to throw some light here.
I think that
Dr.
was a
Amit?
great point, Dr. Rule out lens problems. So, for example, this child, we were talking about the axial length. The axial length is about 26 in both the eyes. So that explains why he has the myopia. His lens thickness is also slightly on the higher side, about 3.7. But it's not a cataractus lens, and no other dysmorphic faces or any other, syndromic signs to suggest that there is syndromic involvement. So it's otherwise absolutely fine. It's just presence of axial myopia quite high in a 4-year-old.
Yeah, I think you can go for genetic testing. That would at least let you know if there are known, genetic mutations which are, whatever is known, whether it is there or not, whether it points to syndromic myopia or not, or whether it just points to a routine childhood myopia. They're not, it would be difficult to come to a very logical this thing based on what you find from genetic analysis. But there's a possibility that you may find a good concluding evidence that this is a childhood. This may progress, and you can plan your treatment accordingly. So I think if there are no further discussion, we can close the session. And thank you so much. Thank you so much, all the experts, Dr. Arun, Dr. Aarti, Dr. Anthony, and Dr. Ipsita. Thank you so much for joining. And thank you so much, all the speakers, Dr. Kalpit, Dr. Amit, and Dr. Sumita. Wonderfully, you have covered the whole topic. And thank you, Dr. Mayank, Dr. Ketti, for handling it all. Thank you so much for joining us today. And module 6 would be on orthokeratology. That will be on Thursday. So thank you so much.
Thank
Thank you, sir.
Thank
Thank you
you.
very much.
Thank you.
Thank you.
Thank you.
And starting this wonderful certification course. Thank you, sir.
Yeah.